So that's the end of part 1. Hopefully you have enough determination to watch part 2. I encourage you to watch it all the way to the end. Share the videos, tag your friends, don't be selfish with the information.
So let's actually start this treatment video with just a quick refresher on how an HIV particle actually takes over one of your CD4 T cells. So here you can see HIV, meeting up with one of your CD4 T cells, right? And then these proteins that are on both of them, right? They sort of start to shake hands, I guess you could call it. And because of this little handshake that they have going on, this secret handshake, the HIV fuses with the CD4 cell, right? And it kind of injects its genetic material and its enzymes into your cell. So the single-stranded RNA that sort of it brought with it gets reverse transcribed and eventually gets made into double-stranded DNA. And then this double-stranded DNA gets taken into our nucleus and then gets spliced into our DNA by this integrase enzyme here. Then our cell starts to crank out viral RNA, right? All sorts of viral RNA. I mean, it actually doesn't have to. Sometimes it kind of lays low and doesn't do anything because it wants to avoid our immune system. But in this case, it starts to crank out all sorts of viral RNA. So some of it's the RNA genome of the HIV, and some of it's viral mRNA, right? Which then goes on to get translated into a viral polyprotein, and then it gets cleaved up by protease, HIV protease, and then it gets packaged into these sort of new, shiny HIV particles that are now mature and really infectious. So now that we've done that refresher, let's sort of just talk about the possible treatments and where along this pathway we can use our treatments. So the key treatment for people with HIV infections is antiretroviral medication, or ARVs. And these aren't cures for HIV, but they're really, really important for a few different reasons. So for one, they can stop people from getting really, really sick with their HIV. They can reduce the amount of HIV in someone's body to levels that are pretty undetectable on lab tests. And, I guess kind of related to that, they therefore make it a lot less likely for someone to pass on the virus to someone else because of these really low levels. So I guess the overall idea, the big idea behind ARV treatment is to keep the viral levels really, really low. And, I should have probably mentioned this a bit earlier, but the reason it doesn't cure an HIV infection is because there's this big pool of infected CD4 cells that get established really early on in an infection, and they sort of lay low, essentially what I showed you earlier. So this pool of low-lying CD4 cells, I guess, infected CD4 cells, they avoid both detection by our immune system, so we can't pick them out and sort of deal with them, and they avoid the effects of these antiretroviral drugs. And then at any given time, they might sort of spontaneously, activate and start producing new HIV infectious particles. But let's talk about the antiretroviral medication. So there's about 6 main types that we use to prevent HIV from working properly. And they all kind of work in slightly different ways. They all have their own sort of flair. So a typical treatment regimen, right, that involves taking at least 2 of these, but preferably 3 of these different types of medications at the same time. And, we don't just do that arbitrarily. The reason we do this is because it's been found that taking just one kind of drug gives the virus the opportunity, the chance to become resistant to that drug. And, that's obviously not very good, but it turns out that giving a few different kinds, right, 2 or 3 all at once, makes it really, really tough for HIV to get resistant to any of them, because essentially the HIV dies before it has a chance to mutate and become resistant. So because of this, before you're actually started on any of these antiretrovirals, you'll probably have some testing done to see maybe which types of medications you're already resistant to. So let's work on our list now. So 2 drugs that we can have as part of our treatment, they start right at the very beginning here. So we've got fusion inhibitors, right? And they bind to this GP120 protein or the GP41 of the virus. And they prevent HIV from binding to and entering our CD4 cells. So they work by sticking to certain proteins that HIV kind of needs to enter our cell. And they stop this fusion step from happening. And we also have CCR5 antagonists, which bind to the CCR5 protein here that sits beside this CD4 protein. So remember, in most cases, this CCR5 is also necessary for HIV entry. So now, all of a sudden, this HIV is going to have a really, really hard time entering our cells. It's kind of like gumming up a lock on, say, your car door or something like that. So you just can't really get the key in anymore and you're kind of locked out. And you got tons of CCR5 proteins all over your CD4 cell, and there's obviously tons of GP41 proteins on HIV particles, but the idea is that you take the right dose of the drug so that you end up with enough little bits to gum up the majority of these proteins. So let's actually keep our list up here up to date. So fusion inhibitors are a type, and CCR5 antagonists, they're another type of antiretroviral. But let's say some HIV does get through it, does fuse, or maybe you're just not on one of these fusion inhibitors. Where's the next place in this sort of pathway that we can block off HIV? Well, remember, this step here is reverse transcriptase, that enzyme, jumping onto the viral RNA once it gets into our cell, and then it starts to make single-stranded DNA out of it, right? Well, we actually have another two types of drugs that work at this stage. So one is called a nucleoside reverse transcriptase inhibitor, an NRTI. So just think about what's happening here, right? So reverse transcriptase is using viral RNA, right? This really nice cobalty blue strand as a template to create viral single-stranded DNA, right? This lighter blue one. So to actually put together this new single-stranded viral DNA, reverse transcriptase has to kind of fish around in the area and grab onto some of our nucleosides that are floating around. And then it attaches them together, right, like end to end, to build a strand of DNA. Remember, nucleotides and nucleosides are the building blocks for our DNA. So what we've come up with, right, what this NRTI does is it's essentially a decoy nucleoside. So it looks just like one of our normal nucleosides, but geniusly, it's missing a key component, which makes it impossible for HIV's reverse transcriptase to attach another nucleoside to its end. And if it can't do that, then this DNA just can't be built, right? It stops being created because it can't be elongated anymore, right? The next piece can't sort of be tagged on, attached on. So those are NRTIs, but another way this reverse transcriptase step can be interfered with is just by gumming up the reverse transcriptase enzyme itself. Think about how Spider-Man catches Doc Ock or the Hobgoblin. He kind of gums them up with his web blaster. And it's a similar thing that goes on here. Obviously, unfortunately, minus Spider-Man. So these drugs that gum up reverse transcriptase are called non-nucleoside reverse transcriptase inhibitors, NNRTIs, because they do inhibit reverse transcriptase, just not by anything to do with nucleosides. They actually work on the enzyme itself. But let's say that HIV mutates, again, as it often does, and then these drugs just don't work anymore. What's the next sort of step? What's the next stage we can interfere with it at? Well, remember here, right? This viral integrase enzyme, it kind of grabs a hold of this double-stranded viral DNA here, and then it tries to bring it into the nucleus to integrate it into our DNA. Well, we have integrase inhibitors that stop this little viral enzyme here from doing what it wants to do. So our drug essentially grabs onto the integrase and just hangs on really, really tight. So then integrase can't bring any viral DNA into our nucleus, right? Which means ultimately it doesn't end up integrating the viral DNA into our DNA. And this step is really, really good. This is an extra important step here because it's been shown that viral DNA integrating into our DNA is a major, major trigger for our cell to undergo apoptosis or self-destruction. So, just as a general rule, the less viral DNA that actually does this integration step, the fewer CD4 cells that we end up losing. So now let's add that to our list, right? Integrase inhibitors. Now, let's say you're not taking an integrase inhibitor. What's the next and sort of last step we'll talk about where you can interfere with HIV? Well, remember that after integration, our RNA polymerase is going to come along, right? And it's going to transcribe this bit of DNA here, including the viral DNA, unfortunately, and turn it into viral RNA and viral mRNA. And then this mRNA is going to sort of hop into a ribosome and get translated into a viral polyprotein. And that'll get cleaved up by viral protease so that a really, infectious working viral particle gets produced, right? Well, not if we can help it. So our last drug that we'll talk about is called a protease inhibitor. And there's actually a few different kinds of these too, but the one I'll mention actually binds to the active site, right? The site that does all the work on this protease enzyme here, the sort of Pac-Man mouth part. And again, it sort of gums it up. It stops it from working so it can't then go on to cleave up this viral polyprotein. So that's good, that's great. Now this little baby virion here won't go on to get mature or become infectious. So you can see that by using some of these drugs, right, in combination, we can really, really minimize how much HIV can replicate within our bodies, right? Because we can stop it from getting into our CD4 cells, which it kind of needs to replicate. And as you saw, we can stop it at a few other places as well. So ultimately, you just end up with a way lower viral load in your bloodstream. You may have heard the term HAART referring to HIV treatment, but what exactly does that mean? Well, HAART, which stands for Highly Active Antiretroviral Treatment, refers to the sort of modern-day present treatment regimen for treating HIV infections. And it's called highly active because compared to the previous treatment regimen, HAART is just a lot more effective, and so the name just kind of stuck. So before we'd give just one type of drug to help control an HIV infection. We'd usually give an NRTI, which stops the reverse transcriptase step in infection of a CD4 cell. But, HIV likes to mutate a lot, and it turned out that when only one type of drug was given for an infection, the HIV would eventually become resistant to that type of drug. So, of course, the drug didn't work anymore, and the person's infection would almost sort of pick up where it left off. It would start to worsen again. Except this time almost more aggressively in a way, because now it'd be resistant to that original type of treatment. But in comes HAART, highly active treatment. And, it's not that we're using totally different drugs. I mean, sure, we've got a few more types at our disposal now, but the key thing is that nowadays we know that if we give 2 or 3 drugs, which is what we usually do in HAART, so if we give 2 or 3 drugs instead of just one, the HIV infection can be really well controlled. And what do I mean by that? Well, each of the drugs in a particular HAART regimen works in a slightly different way, stopping HIV at different points during its replication. So these drugs used together are really effective at preventing HIV from making copies of itself. Its life cycle just won't be able to continue, so new virions just don't end up being made. And if we do encounter, by chance, an HIV particle that's resistant to one of the antiretroviral drugs, chances are it wouldn't be resistant to the other 2 drugs that make up that particular HAART cocktail. And, it'd be really hard for HIV to become resistant to all of the drugs in a particular HAART regimen. I mean, here, let's do some math. Not super hard math, I'll leave that to Sal, but in your body, HIV multiplies essentially, and it creates a few billion new viral particles per day. And during replication, its reverse transcriptase enzyme makes a lot of mistakes. In fact, for every about 10,000 nucleotides it adds on to a new strand of DNA, it makes a mistake and it inserts the wrong base. 1 in every 10,000 bases is wrong. And it doesn't have a very good repair mechanism like we do for our DNA, so this mistake sticks around. So let's say, for argument's sake, that one of these mistakes affects one of our drug's target proteins within the HIV. Let's say this stretch of DNA here was supposed to code for integrase. So this virus's integrase enzyme will still work, but our integrase inhibitors might not be able to stop it anymore because it's mutated. Well, our HAART cocktail would still be able to stop this mutant HIV because we have other places in the replication cycle that we can inhibit it. So essentially, a virus would have to mutate either randomly or sort of evolve by selective pressure to become resistant to all of the HAART drugs that we're throwing at it in a given cocktail. And in fact, the chance that it could become resistant to all 3 of the types of drugs would be at the very least 1 in 10 to the 12th power. That's 1 in a trillion chance. I'm just multiplying 1 in 10,000 here by 1 in 10,000 here by 1 in 10,000 here. And, I'm being really generous here because this is assuming that the 1 in 10,000 base mutations are even occurring at the target enzyme's coding sequence of DNA. So bottom line here is that it'd be extremely unlikely for an HIV particle to mutate during replication in a way that would let it escape from all 3 of the HAART drugs. And, of course, it would be extremely unlikely to thus find an HIV particle just floating around in the bloodstream that's resistant to multiple drugs. Because remember, replication is actually suppressed by taking the ARVs, so once you're on HART, potential mutants aren't even being created anymore, or at least a lot less so. So now you have an idea of what HART is, a drug cocktail, 2 to 3 different types of drugs all taken together that A, makes drug resistance by HIV really unlikely, and B, that's still able to fight off resistant strains that we might encounter. But there's a few other things to consider with HART. I mean, for example, who gets HART, and when is it prescribed during the course of the infection? And how do you sort of take it? I mean, is it a bunch of pills? Is it an injection? Well, let's start here with who and when, because you might reasonably think that, everyone who's diagnosed with HIV gets started on HART right away, and there's good evidence that that is a good idea. But it gets a little complex because there are some drawbacks to starting therapy early, and by early I just mean before the onset of any symptoms or AIDS-defining illnesses, and these drawbacks need to be considered. For example, there are some side effects of the ARV drugs, such as an increased risk of cardiovascular diseases like heart attacks or strokes. There's potential problems with bone health too. Long-term exposure to these ARVs are associated with a greater loss of bone density as a person gets older, more than the normal loss that happens as you age. There can be psychiatric side effects too, like feeling a bit sort of sluggish in your thinking. And there can be gastrointestinal side effects too, like chronic diarrhea. So you can imagine that if someone has HIV but they're in the latent phase, in other words, they're not having any symptoms, starting them on antiretrovirals might actually cause a decrease in their quality of life at that given time period. The other thing that needs consideration is that, if you do start a HART treatment regimen, then you need to stick to it for the rest of your life, taking your medication every single day without fail. Because studies have repeatedly shown that stopping your ARVs, or not taking them every single day as prescribed, is associated with the HIV in your body becoming drug resistant. So that means that in the future, if you decide to start your treatment again, your drugs just may not work as well anymore, or they may not work at all anymore. So when you talk to your doctor about the right time to start your treatment, you'll probably go over some strategies to make sure you can take your medication every single day to minimize drug resistance from happening in your infection. And one thing that's helped out in a huge way for people taking their medication every day is the fact that these combinations of these drugs, remember you're taking cocktails of usually 3 of these types, combinations are available in a single daily pill nowadays, and that makes it a lot easier to stick to your treatment schedule. I mean, a few years ago, and actually still in some countries, you'd have to take a handful of pills every single day, sometimes multiple times a day. And now you can get your whole combo in one single pill, taken once a day, so that's really, really useful. So now we know there's potential problems with starting HART too early. But, when is the right time to start then? Well, it is a little different for each person, so you'll have to have a chat with your doctor about the right time to start. But there's a few general principles that'll help guide the decision that you guys come to. So for one, we know that if your CD4 T cell count is less than about 350 to 500 cells per cubic millimeter of blood, then it's time to start HART. Remember, CD4 count is sort of used as a marker for how far along the illness is, right? The lower the CD4 count, the more damaged the immune system is. Viral load is important too. If the amount of HIV in your bloodstream is higher than 100,000 copies per milliliter of blood, it's time to start HART. And, I guess the last thing I'll say about this is if a person is pregnant, if they're a young child, if they've progressed to AIDS, or if there's an opportunistic infection or an AIDS-defining illness present, then regardless of CD4 count, even if you're higher than that 350 to 500 cutoff, HART needs to be started right away to help your immune system recover as much as possible. So we know that an untreated HIV infection destroys your immune system and leads to essentially an immuneless state that we call AIDS, acquired immune deficiency syndrome. So how do we know when an HIV infection isn't just HIV anymore? How do we know it's progressed to AIDS? Well, in one or both of 2 ways. So here's a graph I'll use to explain. So here's CD4 T cell count on this y-axis. And here's a little timeline, and we'll say that 10 years is about here, because in an untreated HIV infection, it takes about 10 years before your immune system is completely destroyed and AIDS is developed. So when your CD4 cell count has dropped from its normal levels, right, of about 1,200 or so CD4 cells per cubic millimeter of blood, to less than or equal to about 200 cells per cubic millimeter of blood, you've developed AIDS. That's one of two ways to tell. The other possible way to know if you've developed AIDS is if you have any of what are called the AIDS-defining opportunistic infections, which are sicknesses that can only take hold in your body if you have a failing immune system. So regardless of your CD4 count, if you have any of these opportunistic infections, and of course an HIV infection as well, you will be diagnosed with AIDS. So let's do some drawing here to look at what types of AIDS-defining illnesses can come on and when they might come on, because it's important to be on the lookout for signs and symptoms of these conditions, because they can be really dangerous to your health. So generally speaking, people with CD4 counts greater than 500 cells per cubic millimeter of blood are not at risk for opportunistic infections. But, if you're hovering right around 500-ish, then sort of the daily ebb and flow in your CD4 counts means that you might develop some minor infections like thrush in your mouth or yeast infections in the vagina. So thrush symptoms to look out for would be white patches on the gums or on the tongue. And you might also get some pain in the mouth or in the throat, and that would cause some trouble swallowing. And yeast infection symptoms might include vaginal irritation or itching, and also a thick white discharge. And I should probably clarify, so all of these ranges that we're looking at, these aren't set in stone. So you could get certain opportunistic infections at slightly higher T cell counts or CD4 cell counts, or slightly lower CD4 T cell counts. These aren't sort of fixed numbers. These are just sort of ranges. Good. So if your CD4 levels continue to drop, you could develop something called Kaposi's sarcoma, which is a tumor, a set of tumors caused by human herpes virus 8, which can only really infect a person with a weakened immune system. So the classic signs that you should look out for with Kaposi's sarcoma are these purple patches or nodules, growths almost, that appear usually in the mouth, on the gums, or on your skin. If your CD4 count drops even further to between 100 and 200 cells per cubic millimeter of blood, then you might develop some of the more severe opportunistic infections. For example, pneumocystis jirovecii pneumonia, also known as pneumocystis carinii pneumonia, or PCP. So this is a fungal infection of the lungs, and it causes a really, really severe chest infection. And in fact, this is most often the cause of death for someone with AIDS. Two other common fungal infections that might take hold are histoplasmosis and coccidioidomycosis. That's a bit of a mouthful, coccidioidomycosis. And these two are pretty severe because they infect many different parts of your body, not just your lungs. So you can look out for a PCP infection because it presents kind of like a chest infection. So you'd have shortness of breath, you'd have a cough, you'd have chest pain. And, at this point, your immune system would still be able to mount a fever, so you'd have a fever. And these two fungal infections present in a similar way, right? Histo and coccidioido. But remember I said that they're systemic diseases, so these can also cause some weight loss and, just general fatigue. Those are systemic symptoms. Now, if your CD4 levels continue to fall to between 50 to 100 cells per cubic millimeter, you can start to develop opportunistic infections that affect your brain, such as toxoplasmosis and cryptococcosis. So toxoplasmosis is caused by a parasite, and it can cause encephalitis, which is swelling of the brain. And because of this swelling of the brain, or encephalitis, a person might develop neurological symptoms like a headache or weakness of their muscles or seizures. These are all signs of a sick brain. And cryptococcosis is yet another fungal infection, and this one usually starts as an infection in your lungs, and then it sort of moves up to your brain and causes cryptococcal meningitis, which can rapidly be fatal. So symptoms of cryptococcal meningitis would be sort of the classic meningitic symptoms, things like a headache and neck stiffness and a fever. And while we're in this little bracket here, 2 other organisms that can cause serious infections, right, between this 50 to 100 bracket are cryptosporidiosis and CMV, cytomegalovirus. So cryptosporidiosis causes severe gastrointestinal symptoms. So you'd get this chronic, long-standing watery diarrhea because your intestines just aren't absorbing food or water properly. You would get serious stomach cramps, and you'd have severe weight loss. And CMV here, actually CMV is present in most adults, but it only really starts to cause trouble if something's wrong with your immune system. So in someone with really low CD4 levels, CMV can cause problems in the digestive system as well. So the last one I'll talk about happens if your CD4 cell count is less than 50 cells per cubic millimeter of blood. And this one's called Mycobacterium avium complex, or MAC. And this bacteria, sort of similar to all the other bacteria and viruses and fungi that I've talked about so far, they're all present in many different places: soil, water, on trees, really many places in the environment. But again, they don't cause any problems in people with healthy immune systems. We just fight them off. But MAC in a severely immunocompromised person, like someone with AIDS, can cause a really, really serious infection that spreads through the bloodstream to many other parts of the body. And that'll result in things like high fevers, night sweats, diarrhea, all sorts of systemic symptoms. And MAC can be rapidly fatal as well. Now, everything I've talked about, all of these AIDS-defining opportunistic infections, they can be treated with the right medications. So with access to treatment, they don't have to be life-threatening. You just have to get medical help right away. And then once they're treated, the focus would then be on raising your CD4 cell count with ARV treatment, like HAART, so that hopefully your immune system gets stronger and none of these develop again. So let's say this person has extremely low CD4 cell counts, right? Let's say it's because of an immune deficiency like AIDS, and let's say they have a really high viral load as well, right? And we've decided, right, we're their doctor, and jointly, us and them have decided that it's time to start HAART therapy, right? Antiretroviral therapy. So we prescribe the drug, and they take the drug, and everything is cool, everything's good at this point, right? Viral load is going down, all these viruses are being stopped from replicating. That's great. But what else happens when viral load goes down? Well, this is a good thing, but immune cells are going to start coming back, right? That's good. CD4 cells are going to come back, and CD8 cells, and macrophages, and neutrophils, and all sorts of white blood cells are going to start being sort of recreated in the bone marrow, and they're going to start being able to survive in the body without being destroyed by the effects of HIV, right? So I want you to think about something here. Well, we're essentially flooding the body now with white blood cells, right? The plan is to get our level of white cells to pre-infection levels, really healthy levels of white cells. But just what was going on when they weren't around, when their levels were really low? Well, remember, someone with an immunodeficiency, they can pick up opportunistic infections. And these opportunistic infections can sort of lay low, right? And they might not cause any outward symptoms. So the person might have bacteria floating around, or viruses, or fungi, but they might not have any outward symptoms. They might not know that they have occult opportunistic infections. That's what we call infections, or really anything that's not really readily detectable. We call it occult. The problem is, now that the immune system is getting stronger, right? It's reconstituting, so to speak. Now we have the tools, right? The firepower to recognize these occult infections, and we might start to fight against them. And when we start this war, right, this battle against these, they might be bacteria or viruses or fungal infections, our immune cells are going to release these little chemicals called cytokines and little molecules that create a really inflammatory environment, which is normal. That's part of our immune response, and that's kind of one of the mechanisms that we have to call in reinforcements, right, sending out all these inflammatory signals. But sometimes they go overboard. They take it a little too far, and they overdo the inflammatory signals. So there's cytokines everywhere, and this might cause the person to have a really high fever. And there's little compounds that the white blood cells release that are designed to damage the bad guys, but they can actually end up damaging tissue as well. So there's potentially some tissue damage happening. And remember, I said reinforcements are coming in, right? So more white cells are coming in, and this cascade is sort of cascading away, right? Well, this whole thing, right, everything I've described here, there's a name for it, and it's called immune reconstitution inflammatory syndrome, or IRIS. So it's basically a tremendous amount of inflammation, right, systemic inflammation all over the body due to the immune system reacting against bugs that it just discovered upon its sort of return from low function. So I mentioned that the person's going to have a fever, right, a high fever, but they're also going to feel really, really sick when this is happening. And, it's kind of paradoxical, but they might actually start to get symptoms of the opportunistic infections that they have. They might actually start to get worsening of those symptoms, which is kind of interesting. They're just going to feel really unwell. So everything I just described there, that's the classic sort of manifestation of IRIS, when the immune system comes back and then it recognizes that there's all these little bugs running wild everywhere, and then it starts up this crazy inflammatory syndrome. That's the usual way that IRIS manifests. But there's also another fairly common scenario that IRIS can sort of manifest as, and this one's a little bit more bizarre. So sometimes some of the T cells that get reconstituted, that get replenished, remade, and are now patrolling around the body, well, they might run into some dead bugs or little bits of dead bugs, right? Maybe bacteria or viruses or fungi that maybe haven't been cleared out of the body yet. Often a few weeks previously, the person was infected with an opportunistic infection, and they took medication, and the bugs all died off because of the medication the person took. But the dead bugs might just not be cleared out yet. It takes a little bit of time, even though they're dead. But these reconstituted T cells, they might mistakenly think that they've encountered a real threat. So again, they kick off the big inflammatory cascade that we call IRIS. So those are really the two most common manifestations of IRIS. Now, a few things I just want to touch on before we wrap up here. So, does this happen in everyone? And the answer is no. It seems to only happen in about 20% of people who have just started heart treatment. And that's kind of interesting in itself, right? I mean, the same sort of thing is happening in everyone on heart, right? High viral load and low T cells and lots of bugs hanging around and doing whatever they want, and then immune reconstitution. So why only 20%? Why not everyone? Well, the answer isn't completely known right now, but it's thought that a couple things can increase the odds of IRIS after starting antiretroviral treatment. So having a really low amount of immune cells before starting heart, and having any active opportunistic infections or high burden of bugs in your system when you do start heart. And again, these qualities have just been associated with the development of IRIS. And we're free to hypothesize why, but we can't exactly put our finger on why this is the way it is as of yet. But in practice, we just try to minimize the risk of things like IRIS happening by treating any opportunistic infections a few weeks before we start anyone on heart. So the last thing I wanted to say is, what's the prognosis? Is the person going to get better? Are they going to be okay? And also, how do we treat it? How do we treat IRIS? Well, usually the person spontaneously gets better as the immune system gets stronger and stronger. So people usually get better without any extra treatment. But sometimes, just as a little boost, the person might be given antibiotics or antivirals against any known bug that they might have. And that's just to help the immune system fight off the infection a bit more easily. And sometimes if the inflammation is really bad, then the person might be given steroids to tone down the inflammation. That's one of the things that steroids do. So that'll sort of tone things down until the infection has been taken care of. But again, in that 20% of people who get IRIS after starting heart, usually they spontaneously get better without any extra treatment. So let's talk about the ways to minimize your risk of getting an HIV infection. And, probably the best way to do this is to identify the high-risk situations and talk about steps we can take to protect ourselves from infection. in these high-risk situations. And actually, before I get into that, let me just say that there's no vaccine for HIV. So it really comes down to just kind of modifying certain behaviors to reduce our risk of becoming infected. So we can start with the most risky sort of situation, which is sexual activity, right? So sexual intercourse, so vaginal sex between a man and a woman, or anal sex between either man and woman, or man and man, or oral sex between mouth and either penis, vagina, or anus. So if either sexual partner is infected, then all of these activities pose a risk, right, of transmission of HIV from the infected to the uninfected partner. So strategies to reduce or prevent HIV transmission in these scenarios, well, you could totally avoid all of these activities, right? Abstinence from sex. But whether or not that's something you're willing to do is really up to you. But abstinence is really the only way you can be sure that you won't get an infection. So, and actually, let's make a nice little list up here. So ways to reduce or prevent HIV infection. So abstinence. But other options to reduce the risk of transmission are things like using condoms in any of these sexual acts, right? Vaginal, anal, or oral sex. And also things like having less risky sex, because, it turns out that anal sex, for a variety of reasons that we've touched on before, is by far the highest risk sexual activity for transmission of HIV between either partner. So being extra careful and making sure that condoms are used in situations like this in particular is extra important in reducing the risk of HIV transmission. And oral sex is actually the least likely form of sex to facilitate HIV transmission. But again, in all three of these activities, barrier contraception like condoms can significantly reduce the risk of HIV transmission, provided that they're properly used, right? And that's because they're literally a physical barrier, right? Like bulletproof glass that is really effective at preventing any virus from getting across the condom from one partner to the other. And I guess another strategy in this, the sort of sexual domain is to reduce the number of sexual partners that you have. And this is for two reasons. So one is that the more sexual partners that you have, the higher the likelihood is, right? I mean, even if it's still a small likelihood, there's still a higher risk that one of your sexual partners has been exposed to HIV. Remember, often there's no outward symptoms of an HIV infection. So limiting your number of partners, or just having one uninfected partner that you're in a monogamous relationship with, that'll reduce your risk of becoming infected. And the other reason why limiting your number of sexual partners is a good idea in this sense is because, well, the fewer the number of sexual partners, the less likely you are to be exposed to any other STI, any non-HIV sexually transmitted infection. Things like chlamydia, gonorrhea, syphilis, herpes. And this is important because a lot of STIs manifest as sores or otherwise sort of broken skin in the genital area. And as we know, broken skin and maybe blood in that genital area, it makes it a lot easier for HIV to cross from one person to another, right, through that broken skin. So I guess we can add that to our list, right, avoiding STIs and treating them if we do have them. And actually, I touched on this a bit earlier, but let's officially put it on our list, getting ourselves tested. So we know our HIV status, right, positive or negative, and knowing our partner's status as well, whether they're positive or negative. Now, we can sort of leave this sexual domain there and we can move on to other ways to prevent HIV transmission. So we know that sharing needles in IV drug use, intravenous drug use, like say sharing heroin injection needles, that activity in particular poses a really high risk of transmitting HIV from one user to the next. Because, I mean, if you think about it, the person's blood, right? One person's blood is going directly from the tip of the used needle straight into the next person's bloodstream, right? And that tip, right, that bit of blood might have some HIV in it. So I think the best way to prevent HIV transmission here is to just absolutely refrain from using IV drugs, right? Don't inject drugs. But if you do, then you should only use sterile equipment, like brand new needles, i.e., you literally opened the packaging yourself, and then don't ever share your equipment with anyone else. that'll cut down on your risk of becoming HIV infected through IV drug use. Okay, so those are two of our higher risk activity groups, right? Sexual activities and drug use. But now we're going to change gears a little bit here. So the other higher risk ways to transmit HIV actually have to do with pregnancy and breastfeeding. Because during pregnancy and labor and then the subsequent breastfeeding, there's a chance, right? And sometimes actually quite a significant chance for an HIV infected mom to pass the HIV on to her little baby. So ways to prevent or at least drastically reduce the risk of transmission of HIV in these scenarios is to take antiretroviral drugs, or ARVs. And ARVs work by reducing the amount of virus, right, the viral load in your body, both in your blood and in your secretions, so things like your breast milk or your genital or your sexual fluids. So simply by taking your ARVs properly, you end up with a way lower risk of passing on any HIV to your kiddos, right? And you know, this method of preventing transmission, this will be effective in every situation we've talked about so far, right? So any sexual activities, any IV drug use, just lowering the amount of HIV in your body using ARVs, that will directly reduce the risk of transmission to another person. So the last thing I'll say is that there's medications called pre-exposure prophylaxis, or PrEP, and post-exposure prophylaxis, or PEP. And these medications can reduce your risk of becoming HIV infected before or after any high-risk situations. So let's just expand on that a little bit. So pre-exposure prophylaxis, that's a set of medications that are given to people who have a higher than average risk of contracting HIV. So for example, you know, HIV negative people who are in relationships with HIV positive people. So in addition to condom usage, right, these medications aren't really supposed to be used on their own. So in addition to condom usage, the person can get pre-exposure prophylaxis drugs, which are basically just ARVs that have a good chance of stopping any HIV that gets inside the HIV negative person's body from actually succeeding in causing an infection in the uninfected person. And post-exposure prophylaxis, again, are ARVs that are to be given pretty quickly after an HIV negative person has just been exposed to HIV. So, you know, maybe it's a healthcare worker who was accidentally exposed to HIV through, say, a needle stick injury. Or maybe someone has had unprotected sex with an HIV positive person. So these two types of drugs are just ARVs that have a good chance of stopping any HIV that gets inside an uninfected person's body from causing an infection. And these PEPs work best if they're given within an hour of exposure, but they'll still work up to 3 days after an exposure.